My name is Megan Haupt. I'm Chief of Staff with the National Association of State Mental Health Program Directors. I'm thrilled to be here today to host a Crisis Jam, and we are going to have the featured presentation from Dr. Stefan Kertesz, and he will be talking very much about what Matt just presented in the video and the implications for crisis system. Next slide, please. And I just want to emphasize that the Crisis Talk and the 988 Crisis Jam Learning Community can be found on this website, crisisnow.com, the Zoom link, all the past videos, past hot seats, new resources, it's all there. So we highly encourage you to just stay on mute, though, unless you're presenting. And so just really thrilled that this can all be found in one place. Next slide. And if the 988 Crisis Jam disappeared from your calendar, because normally it's a running calendar and there's a way to get it back on. And so how do I get there now? So you can contact Karen Jones and be able to also in the chat, it looks like you're also able to download for the Crisis Jam invites. Okay, next slide. Great. And the Crisis Jams, this is the top 5 viewed Crisis Jams. So there's the Crisis Jam Live, but then of course we have them also up on YouTube. And these are the top 5. And usually they are those special events, that Youth Edition, when 988 went live, when there's a technology edition. So these special events really got some high views. So thrilled for that. Next slide. And then this is part of the top 10. And this is a new view. And this really has to do with the topics. What's really cool is the number 6, 7, 8, 9, and 10 really hones in on where there's such strong interest on those specific topics, like mental health and police, threat assessment and response, law enforcement coordination, LGBTQ populations in 988, EMS and 911 coordination. All of those drew a lot of attention. Next slide. And now we are going to move to, if Stephanie Hepburn is on. Stephanie, are you on?
Yes.
Wonderful. Okay, I'm going to move it to Stephanie Hepburn to talk about the Crisis Talk article for this week.
Thank you. So I'll bring on Dr. Carol Olson. She's the chair of the Department of Psychiatry at Valleywise Health System in Phoenix. And I believe Dr. Olson did her presentation about a year ago, a little over a year ago, on the JAM. And in our interview, what stood out to me, Dr. Olson, is that it's not just coexisting medical conditions that psychiatric hospitals often exclude, but also people with psychiatric challenges that might be more complex and costly. Can you talk about these barriers?
Sure. I have noticed very much that it's very popular. We have a lot of new psychiatric hospitals in the Phoenix metropolitan area where I work, but there are large numbers of individuals presenting for crisis services who need a longer period of stabilization in a hospital setting, who are being excluded from consideration for admission at various hospitals. And there's several categories. One are people who have a purely psychiatric condition, but it's one that is relatively treatment resistant, likely to require a fairly long period of time to treat. And the person's behaviors are such that they may require increased levels of staffing, for example, one-to-one staffing, or they might be destructive of the environment at times, and hospitals are unwilling to take those patients. And then there are patients with medical comorbidities, for example, people who need tube feeding or people who need dressing changes, even relatively minor medical conditions, like someone who has stable emphysema and needs to be on 2 liters of oxygen routinely, which they've been doing at home. when that's needed in a psychiatric hospital setting, it often means, because of the ligature risk of oxygen tubing, that they need to have a one-to-one, and then that leads to hospitals refusing to take those patients. And then there's individuals who have other types of conditions, such as comorbid autism or other types of developmental disabilities, where hospitals will feel that they don't have the expertise to treat that person, or that they won't fit into their milieu is sometimes the terminology. And so those individuals really don't get appropriate care. Often they're kept for several days in an emergency room or a psychiatric crisis center. It's not an ideal environment frequently, and often they get discharged at the soonest possible moment before they've really had any their problem definitively addressed.
And in the article, you highlight these nuances, but you also talk about solutions. If you wouldn't mind sharing one possible solution that you've thought of.
I feel like it would be better if the reimbursement system for psychiatric hospitals mimicked in some ways some of what is done in acute care hospitals, with regard to recognizing that there is an increased level of expertise, staffing, medical services, et cetera, needed for some of these higher and more complex cases, and that those services are costly. And in an acute care setting, there's often funding that goes, say, with being a trauma center. If you have a trauma center, you get some additional funding related to that. And then there's different levels of trauma centers. And that's meant to compensate for some of the increased costs that are associated with providing that level of care. And that type of reimbursement system is really not common in the behavioral health side of things.
Well, thank you so much for hopping on with me. And like I said, Dr. Olson fleshes this out more in the article, and I would love for you all to take a look. Thank you.
Thank you.
Thanks.
Dr. Olson, and as well as Stephanie, you just do great work on these articles. And Dr. Olson, you just make great points. I hope that you can see that in the chat, that people really valued what you shared.
Thank you.
And next slide. Great. And this is the SAMHSA store, right? There's the 988 suicide crisis lifeline at the SAMHSA store. You can get stickers and safety plan pads and wallet cards, and there are Spanish options. So we encourage you to get some of these materials. You can receive up to 326 materials for free. Go for it. And we've got the t-shirts. Now these t-shirts are great. I have one, and one of our people at Nashville staff developed one of these quotes, and there are quotes that you can choose. There you can get long sleeve, you can get hats, you can get short sleeve, you can choose your logo. They're also updating the Spanish versions and adding some of the quotes in the near future. So we're really excited about that. Next slide. Great. And now we're at the Crisis Trivia Hot Seat with Sabrina Taylor. Sabrina is the CIT coordinator and detective for the Phoenix Police Department. She is right now at the CIT conference. And so we are really excited. Hi, Sabrina. And there was also a piece that she did on a day with police CIT, which was done by KTAR News. And she is a Crisis Jams go-to for the trivia Phone a Friend. So go Sabrina. And so she's in Detroit today for the CIT International Conference and is coming live from there. Hello, everybody. And so the whole group is going to be.
Hello.
Hello. So let's go to the question. All right, Sabrina, are you ready? Yeah, there you go.
We're ready.
Excellent. Okay, and
We're ready.
Okay, excellent. Dr. Rahul Gupta is the first physician to serve as director of the Office of National Drug Control Policy In February 2022, he spoke with CNN on the disparate overdose death rates experienced in the US compared with other countries. So Dr. Gupta described a progression of primary challenges, which is the most recent: A, prescription opioids, B, heroin injection, C, fentanyl cut with heroin, or D, fentanyl with stimulants like methamphetamine. Sabrina, what do you think? And audience, please, the poll should have popped up, so choose what you think. And by the way, either way, Sabrina, you get a free Crisis Jam t-shirt, one way or the other.
We have the t-shirt, but I'm looking at a whole bunch of blank faces. The room does not know the answer. It's D? All right, the room is saying that it's D. What does the audience say? All right.
Yeah, the audience went with that. Wow. Well, let's see. So indeed, it is D. Congratulations to you and the audience. Fantastic job. In July, the CDC released data showing opioids mixed with cocaine and psychostimulants are driving more overdose deaths. The report does not specify the type of opioids involved, but experts say these trends highlight the dangers of illicit fentanyl. So well done, Sabrina, and your team at CIT International. Great, thank you so very much. So nearly 1 in 10 adults in the US has lost a family member to drug overdose, the new KFF poll finds. So that's the latest in the crisis news. And so that's reported by CNN August 15th. So check that out. And that's in the chat. And the quote, we love sharing quotes, and they kind of drive information home. And this is from Maya Slotsvitz, whose opinion guest essay of the New York Times for January 2023. Patients who are abandoned to withdrawal and untreated pain have an increased overdose death risk, nearly 300%, and their risk of suicide is also significantly elevated. If thousands of them hadn't been cut off in the first place, the enormous street fentanyl market that now exists might have been minimized rather than given rocket fuel. It is both cruel and nonsensical to increase patients' risk of overdose death and suicide in an attempt to reduce these harms. So great information right there. Next slide. And so now we are going to move to our featured presentation, who it's Stefan Kertesz, who is the professor at University of Alabama, and he is an intern as well as an addiction medicine doctor and the investigator for Birmingham, Alabama VA healthcare system. So Dr. Kertesz, I will turn it over to you. Thank you so much for being here today.
Hi, and thank you so much. I'm super excited about the Crisis Jam, Crisis Talk today. Suicides after prescription opioids are stopped. That's our focus. We're trying to move beyond statistics to understand what is really going on using a study that is funded by the U.S. Department of Veterans Affairs, but is not restricted to veterans, but includes any suicide that's occurred in the U.S. After prescription opioid stoppage. Let's go to the next slide. I want to acknowledge that in that photo you saw part of our team, the Birmingham side, but there are members of our team who are on the call today, both from University of Alabama at Birmingham, from Florida State, like Tom Joyner, advisors, patients who have lost patients who have pain, patients who have lost people who had pain. But the scenario is as follows. There has been a very large decline in prescription of opioids that has returned the United States at a per capita level to the prescription level we last saw in 1993, according to data from the Food and Drug Administration. The reduction of opioids in those patients who are on medicines long-term with pain and who had been receiving those medicines is a very unique situation. And there are 5 to 9 million people in that group, many of whom need those medicines. Suicide that follows reduction in prescribed opioids, whether it is instituted step by step or all at once, has both the CDC's attention and the Food and Drug Administration's attention. The reduction or the stoppage often does present as a crisis. And what is missing right now is credible, actionable knowledge of the factors that can help explain and prevent the tragedies. Next slide. That story came to my mind because of a woman who lives here in Birmingham, who's on the call, Ann Fuqua, who has long-term pain herself and is an advisor and employee of our study now, but she was tracking deaths by suicide for the last 8 years. And she has, close to 1,000 reports of suicides, but they aren't all easily validated, and we can't directly take her data for research. But she has advised me that she has 251 where she knows the name, that was as of 2 months ago, of the person who died, 52 where the name wasn't known, but a credible source, like a doctor we know, knew about the person who died, and many more where there wasn't a reported name. Often these emerge on social media. And her work was featured by Maya Salovitz in the New York Times in December. And a very dramatic example was after a physician was shut down and 3 people died suddenly, at least 2 of whom by suicide last November. Next slide. Observational retrospective studies, I'll just summarize. There are 14 studies to date that show an adverse association between opioid dose reduction and the safety of the patient. That is opposite of what many doctors and health systems understood would happen when you reduce doses on a long-term pain patients. The outcomes can include overdose or mental health crisis or suicides. Those are higher, but it's not always with a rapid reduction. They aren't always adverse effects. There are plenty of people who want to go off of their long-term opioid medicines and achieve that successfully and find that it is helpful. Health record databases, which are how most people do research, are a problem. They lack timely, accurate, or rich information about what really happened, particularly for an event like a suicide, which is pretty complex. And one thing I want to emphasize is that it is not likely to simply be acute withdrawal like you saw in that video at the beginning, much as you would see in somebody with ongoing heroin or OxyContin addiction, because many of these events occur at long delay after the reduction. So what we don't understand vastly exceeds what we do. Next slide. When we want to understand a complex tragedy, we have a variety of approaches. And to illustrate that, I'm picking an example from another field. In the late 90s, TWA Flight 800 exploded and crashed 12 minutes after its takeoff from JFK. 280 people, 30 people died, and many people reported having seen a streak of light, which they thought represented a missile or something going toward the plane. And there was a dispute between government agencies about how to evaluate the crash. Imagine if we looked at that crash the way most medical scientists are currently studying loss of life after opioid reduction today. Next slide. Here's how people in my business, the medical science business, typically study complex tragedies. Click, please. They would take all the airplanes that went into the sky in some common database, and they would say, 99.9% stayed up and 0.1% went down, or maybe it's even smaller. And they'd say, whatever's in the database from the airports and the airlines, we'll call those standard data elements. And we'll just compare the planes that stayed up and the planes that went down. And hopefully something will pop out of the statistical machinery. Pilot age, aircraft age, weather, maybe, who knows? Are those even the things that matter when you want to explain why that TWA flight went down? They'll then report odds ratios and be published in JAMA or JAMA Network Open. I've published in those journals with exactly this kind of study, but it's a little bit hollow. Next slide. This is not how we explored TWA's crash in 1996. Federal agencies pulled together all the parts, reassembled them, and concluded after careful study that there was an explosion due to ignition of a flammable fuel air mixture in a hot and mostly empty center wing tank. And they created rules to prevent that particular kind of crash after studying the individual case. And there is really no chance that large database statistical analyses would have helped prevent future such crashes. That's why we need to look at cases. Next slide. So our study, CSI opioids, starts with the supposition we need to do what's called psychological autopsy and look at roughly 115 individual deaths by suicide, which we have to recruit from the public. There's no master list. This type of work began in 1963. Our study is up and running 60 years later. CSI opioids, clinical context of suicide following opioid transitions. We're not even saying that the opioid transition is the simple cause of a death by suicide. Most people don't die by suicide. We need to know the context. Next slide. So what could we learn? And we're going to click through a few questions. How many decedents had a rapid or a slow opioid taper? And did they feel they had control over that? How long after a dose change was there any hint of potential for self-harm? How many had psychological diagnoses? How many shared concerns with family or friends? How many had risk factors for suicide, such as a perception that they were burdensome to others or a thwarted sense of belonging? Did healthcare feature conflicts or impasses in care? And I see those when I read records, by the way. Next slide. Click. Was there a medication or a firearm? And for veterans, how many went outside of the Veterans Administration? There are many other questions we might ask, and I invite people to contact us and contact me with things that you think we should look for when we study these cases. I'll put my email in the chat when I get a chance. Next slide. So our study involves outreach to the public, seeking the survivors. That's why, part of why I'm here speaking. There's a screening survey. I'll have a link to that later in this talk. People then who qualify as having potentially suffered this kind of loss are offered a more detailed informed consent. And then they participate jointly in medical record solicitation and a detailed survey and interview, which we are doing now. And then we try to create a synthetic autopsy report for each death. And we're just beginning this process. We're about 7 interviews in at this point. Next slide. There are many challenges to this research, and that's why no one else is trying to do it. Recruiting the survivors, there's no master list. So this is inconvenient for medical researchers, but very important if we want to understand the problem. Once you contact people or hear from people, how do you stay in touch with them? We have to go to the public, and the public includes people who are themselves in crisis related to pain and afraid that they're going to lose their medicines. There are complex issues of data security to protect all information that comes to us such that we will never release it. People have a lot of fear and a lot of distrust of researchers in the medical space who are very focused on opioids. Very often they have not shown particular interest in or sensitivity to patients with long-term pain. And there are ethics and safety issues. And we operate under 2 institutional review boards with 2 guarantees of confidentiality. We cannot even release our data under court order. Next slide. So if you go to the public, as I mentioned, people who are being dose reduced or cut off currently have no crisis support. There's almost no recognition that they deserve crisis support. Whether they live or die is not a priority in almost any federal office except for 1 new program in the CDC and a few small groups, basically. As soon as we started the study, I put up on my own medium.com website a guide for families and patients who are at risk from a dose reduction they did not choose. Also, I took note that the San Francisco Department of Public Health has a toolkit and an initiative to advise clinicians who have inherited patients on long-term opioids. Next slide. These are just ethically required if you're going to do this work. So if we want to make a difference, all 215 of us and that entire auditorium on this call, we need to understand that crisis response communities can't easily resolve a crisis where forces across healthcare are actively contributing to that crisis at this time. That includes health plans that are requiring dose reductions, even if the patient has not consented. I'm looking at you, Kaiser, Northern California. prescriber bias, lack of conceptual framework for understanding pain care, which is rather debated, and lots of fear. And there are shortages of the medicines that patients are on owing to supply controls and litigation. The population at risk is not recognized. So I ask you to share word of our study, both for people who might wish to report a suicide and participate, but also because they are, this will help make public officials pay attention to a serious problem. Now, there are resources, and I want to mention them. There are individual pain clinicians in states who are trying to take on patients and provide guidance. There's websites like the San Francisco Department of Public Health website with the toolkit. There's addiction treatment programs that sometimes are receiving pain patients and saying straight up, we know they're not really addiction patients, but we're taking them because we're not afraid to take care of them. There are health plans that are making changes and trying to avoid harm to patients. And there are federal and state officials who are really paying attention to this, although the momentum is not there yet. Next slide. I urge you to take a photo if you can, to consider sharing information about our study with major mental health groups, with veterans groups, with people who have sickle cell disease, with families that are dealing with suicide loss. These are QR codes for the general study website on the left. Also, the IRB approved screener. You can be screened if you think you've lost someone, that's the middle, and a one-page information sheet that you can email to anybody who might want to learn about the study, which is on the right. Obviously, these are easily available and very public. Next slide. We're probably done, I suspect. We are at the roundtable phase.
Dr. Kertesz, thank you very, very much. This information, it obviously is very new for people. We really appreciate you bringing it to light. And what a huge issue to have to take on, especially when there's the mistrust as well as the desire to advocate for people getting what they need. And so I also want to acknowledge that your public advocacy on problems that result from the non-consensual stoppage of prescription opioids. You're just really sharing some information we all really need to know. And so we're going to go to our roundtable, and the next two people have been involved in the study. And so the first person, if you could click the slide. Is Kate Nicholson, the Executive Director of the National Pain Advocacy Center. Kate, if you could give us your impressions, your thoughts, and what it's been like to be involved in the study.
Hi, everyone. It's a pleasure to be here today. I have been involved in the study, but the National Pain Advocacy Center has also been involved in changing policies on these issues for several years. So I want to begin by putting a human face on the topic and mention a couple of people I've interacted with in recent years. The first was a very successful artist living in the New York City area, and someone who had been placed on higher dose opioids for many years. He then began to be force tapered by his provider, and that's the point at which he reached out to me. We tried to help equip him to advocate with his provider, but he continued to have his medication reduced, and he suffered significantly. He lost the ability to paint. His relationship eventually suffered as well. He still persisted to try and get better care for himself, but eventually died by suicide. And this past Sunday would have been his birthday. I think it's important also to mention, since we're in this crisis jam environment, that it's not just people already on opioids who are at risk. Another person I interacted with was, like me, a lawyer working in Colorado. She had significant chronic pain, but struggled to get providers to believe her pain. She tried a lot of ways to manage it, but it remained undertreated. She too was very persistent in trying to get care, but eventually experienced one rejection too many and also died by suicide. I think it's important to mention that these people and many others we talk to are really working hard to get help, and it's our systems that are failing them. So I feel like this study and crisis lines are critically important. But I think it's important to mention that crisis lines aren't regularly trained in talking to people with chronic pain. They should be. It's a fantasy of mine that they would be, because chronic pain carries significant risks of suicide and suicidal ideation, even separate and apart from mental health conditions like depression and anxiety that often can accompany chronic pain. Just the unrelenting nature of incessant day and night pain, often for years on end, can drive a desire for suffering to stop by any means. And then we add on the results of our policy choices in the opioid crisis and the consequences for people Stefan is working to study, people who did not put themselves on medication and are being dropped in care and ripped off their medication. And both of these situations, numerous studies, as Stefan mentioned, show significantly exacerbate the risk of suicide. So the picture becomes pretty bleak. And I want to also reiterate what Stefan said, that it's not just abrupt tapers like that was shown, like what was shown in the video. Studies have shown that even slow tapering exacerbates risk, and that the risks can continue up to 2 years after dose has been destabilized. So the crisis is much bigger than just opioid withdrawal, and especially for people who are doing well on the medication, it means losing their pain management. I also noted, as you flashed the slides in the early part of the program, that a number of the slides dealt with different populations. And I think it's important to underscore that there's lots of evidence showing that not everyone's pain is treated equally, not everyone is given medication at the same level, and not everyone is tapered in the same way. So Black, Indigenous people of color, women, members of the LGBTQIA+ community, and as the first speaker noted with respect to psychiatric care, people with disabilities all face disproportionate barriers to access. And we're talking about significant numbers of people. 50 million people live with chronic pain in this country. 17 to 20 million suffer pain so severe that they cannot engage in the most basic life activities or work. And being shut out of social and economic life costs the person, their families, and loved ones, and society as well. And as many as 8 million Americans, according to the studies that we've seen, use opioids to manage pain. And I just want to end by underscoring the other thing that Stefan mentioned, which is, it would be wonderful to have crisis lines trained, but they can only go so far if the healthcare system is failing to treat people and literally turning them away. One recent study showed that 40% of primary care practices won't even take on a patient who's using opioids to manage pain. So people are really being stranded with nowhere to turn. Thanks.
Thank you so much, Kate. Again, just emphasizing the points that are just so important to pain management, and noting that the slow tapering is also dangerous. It's not just the abrupt stopping, or that somebody who doesn't have any pain management is also at risk. So thank you for bringing so many points to light. And Dr. Thomas Joyner is here to be with us. Dr. Joyner, thank you so much for being here. You're a Nancy Marcus Professor, 2023 to 2025, and the Robert O. Lawton Distinguished Professor of Psychology for Florida State University. So thank you so much for being here. Please give us your reflections.
Thank you, Megan. Happy to do so, and happy to be on this call again and see everyone. Many of you, or some of you anyway, may know a little bit about me and my work, and if you do, you know that I'm pretty seasoned and experienced in this space of suicide prevention, and yet I've learned many things from Stefan and his team and the project, including this phenomenon of how opioid stoppage is potentially complicated. It's not always a good thing. As Stefan said, it can be, but it also cannot, it can be quite different. Just depends. And that phenomenon by itself, I just think needs to be reiterated. It's so surprising to a lot of people, including in the healthcare professions, that this can be a problem. But once you stop and reflect on it, it makes a lot of sense. The other thing I would note is that in a lot of our work on suicide prevention, we emphasize themes like feeling that you're not a burden and feeling like you do belong. And if you reflect on the opposites of those states, what's the opposite of feeling like you're a burden? Well, it feels like you have capacity and capability and competence. And what's the opposite of feeling like you don't belong? Well, obviously it's feeling like you do, like you're socially connected. And these experiences that Stefan specializes in, they definitely have the potential to spur feelings like incapacity, incompetence, inefficacy, burdensomeness, loneliness, disconnection, alienation. Lately, we've been studying or theorizing along the lines of it's really key to, in one way or another, feel at home in your body. If you do, that's a suicide preventative, feeling at home in your body, comfortable with who you are, at home in your physical embodiment. But if you don't feel that way for any reason, well, that can be, it doesn't always have to be, but it can be a risky state of affairs. And certainly there are some people, as Stefan's work has illustrated, that feel this way as they're in many cases forced to go through opioid stoppage. The one bottom line that I would like to close with is that I'm part of the research project, and we're very interested in recruitment. And so I just want to reiterate that point too. If you know of people who have died by suicide and maybe qualify for this psychological autopsy study, by all means, get in touch with our team. And I want to turn it back over to Megan or maybe to Stefan to reiterate the recruitment point that I just made. Thank you.
Thank you so much, Dr. Joyner. And Stefan, do you want to make any comments on that in terms of recruiting? Yeah.
Sure. So there's a screener survey. First of all, there may be people who are not sure they want to engage at all. And there's a general website that I will type out now, which is at UAB, and it kind of is more of a general, here's what we're about, here's what the study does, here's our advocacy, and here's our scientific record. And that's the second website I just typed into the chat. There also is a screener survey, and the screener survey is about 30, 40 questions, one of which is, do you think that someone you were close to died by suicide after a change in prescription opioid medicine? It doesn't require you to believe that that was the cause. In fact, we're interviewing people and we know the stories are diverse and they're different. But the questions are fairly direct. What do you think happened? Why do you think it happened? Are you in the United States? Were they in the United States? Are they adults? There's a mini informed consent even just to do that survey. And that survey is pretty brief. I put the full website there first. It's a little bit long, but it's also go.uab.edu/CSI opioids. And remember, there were those QR codes also in the slide set for where you can find the entry survey. We digest the responses that have come in, and we need more people to see that entry recruitment survey. And then we invite people back to us if they seem relatively confident that the event was a death by suicide, and they seem relatively confident, they don't have to be perfectly so, that there was some sort of reduction in opioid pain medicine. That's it. We are not studying children at this point. We aren't IRB approved to do that. And then we reach out with an informed consent of a greater detail. And if people want to be interviewed, they're interviewed. The data on these interviews, I don't have results yet, but I can say people who want to be interviewed usually benefit from the interview or find it not to be very stressful. That is, they wanted to speak, and then we speak with them and they tell us the story as they know it. And some of them describe feeling disconnected or feeling like somebody had lost their role. Some of them focus on what happened to the doctors. But those rich stories are a bit like, the stories of, unfortunately, the tragic airplane crash. Why did things go south at the end? And we're trying to understand that story. So it's available to all. If you are connected to a national mental health organization like NAMI or National Suicide Prevention Organization, we are on the road and we will present anywhere. And I'm happy to talk about this issue, as is Kate and Tom, and just let us know. And I'll again put my email address into the chat.
Fantastic. Thank you, Dr. Kertesz. And I want to just note that Kate Nicholson said, I want to reiterate how important CMS's recent coding for chronic pain management is. So check out the chat there. There's a thread that talks about that recent coding. So thank you very, very much for this information. It's absolutely enlightening and a problem we have not seen until now at this level. And now we're going to move to the SAMHSA update, and we're going to move this to Richard McKeon.
Thank you so much. So one thing I would like to highlight is that SAMHSA just released today our 2023 to 2026 SAMHSA strategic plan. You can find it at the homepage of the SAMHSA website. And it has a number of important things I would just like to emphasize in terms of its focus on suicide prevention and crisis care services. Goal number 2 in this strategic plan is to save lives and improve well-being. SAMHSA will lead public health efforts to reduce suicidal ideation and behavior. And then there are numerous objectives underneath that I would call people's attention to. Goal number 3 is to develop crisis care across all communities. SAMHSA will improve the quality and accessibility of the crisis care system. And again, that also includes a number of objectives to try to move that forward. So again, I would call everyone's attention to review the SAMHSA strategy as a whole, but particularly those sections on suicide prevention and crisis care, but many other parts, substance use, etc. Given our presentation today, really, would be useful to people to take a look at. I'll also just mention briefly, if people haven't seen it, and this is something perhaps that the Crisis Jam could do an invitation to CDC on shortly, is that the 2022 preliminary suicide mortality data came out about 10 days ago. And tragically, there were over 49,000 deaths by suicide, the highest number, not necessarily the highest rate, but the highest number of suicides ever. While that, of course, is tragic, there were kind of islands of optimism when you look at some of the variation. This is not the optimism. Older adults as an age group had the highest increase of about 7 or 8%. But youth suicide, age 10 to 24, actually went down. I think it really calls our attention to our crisis care services about continuing the work with youth that's already been underway, but looking at how we improve access for older Americans. Also, for the first time in my memories, suicide among American Indian Alaska Natives went down. But we might want to consider inviting CDC to share about the preliminary data for this group on a future crisis jam. So that's what I have. Thank you very much.
Richard, thank you very much. So excited that SAMHSA has a new strategic plan and that we can build upon that. And thank you also for your insights on the data. It is interesting, that the numbers are up, but that there are reflections of the good work happening And so let's move to the NASHBID update. And we have Arlene Jensen, who's one of our advisors at NASHBID. Arlene.
Hi, Megan. Good to be with you.
Yeah, good to see you.
Struggling here with my. Oh, this is not what I wanted.
You sound fine. You're doing fine.
Okay.
Go for it.
Okay.
Yeah.
All right. I can't pull up my document because I can't make this screen go away.
Can you see?
Oh, okay. There we go. I think I've got it now. Yeah, finally, I remembered what to do. I need to practice more often. Good afternoon, everybody. I'm happy to be here with you today. Today, I wanted to talk about some changes that are going on between 988 and 911. The transition to the suicide lifeline last year was a major step toward creating a tremendously more effective behavioral health crisis services system to serve our country. But there are more steps, and one of those next critical steps is ensuring that there's collaboration to achieve interoperability between the Lifeline centers and the 911 public safety answering points, and they call them PSAPs. Changing people's habits to dial 911, to dial 98 rather than 911 for behavioral health crisis is going to take a long time, even years. So achieving fluidity between the two systems will ultimately connect Americans to care immediately. But it also might add some efficiencies to the system. So just a little bit more good about it. NASHBID wanted to help the states move in the direction of making this happen. And so we wrote a paper, and you'll see that on your screen, I hope now, the cover of it. And it's called 988 and 911 Interoperability, Leveraging Strengths and Opportunity. The paper hasn't been released yet, but it will shortly. And I'd like to give a call out to my co-authors, April Naturel and Amanda Miller from Vibrant, and Deb Pinels and the amazing Jenna Schofield, who are with NASHBID and coordinated everything that's related to the paper. The paper discusses how to achieve fluidity, and that includes key types of stakeholders that you need to involve. It provides a list of topics that you need to discuss and make decisions about. It covers best practices and possible models, and provides examples of operating models. While interviewing the states and the national associations, we learned that collaborations are taking place, but they're not taking place in a majority of the states, and that collaboration approaches are variable and they're in different stages. So we're kind of everywhere. And sadly, or maybe even embarrassingly, the 911 or 911 PSAPs and EMS are troubled, or their feelings are hurt that we're not talking to them. They see ads and they want information, and they want to be involved. The collaboration will be a major undertaking because there are many parties that really need to be involved. The states and counties, the Lifeline centers, the PSAPs, and there are almost 6,000 of them nationally, and individuals with lived experience, but also responders like the mobile crisis teams, EMS, fire departments, ambulance services, and law enforcement. So we're thinking, let the discussions begin. There's so much to do. Stakeholders need to become familiar with a lot of the different aspects of this. There are issues, with data and call transfer capabilities and technologies. We need to address liability issues and locations with service gaps. We wanted to develop procedures and protocols. 988 messaging is an important part of making this all happen. And so targeting that messaging to at-risk and marginalized populations is important. Stakeholders, along with the representatives of those communities, are the right groups to help with the targeting, and also to address the issues of mistrust of 911 that prevails. And we need to attempt to resolve that as 988 and 911 begin collaborating. This is important to SAMHSA. In fact, I wanted to mention that they specifically asked us to address the issue of targeting and of mistrust in this paper. And so we thank them for that and for funding the paper too. These changes may include culture shifts that might potentially be difficult for some organizations, that, especially those that are accustomed to being the protectors of the public. It may be difficult and even awkward to get started working on these collaborations. We speak differently. I laugh, some of these groups talk in acronyms, and we dress differently. Some of them wear uniforms, but it's encouraging to know that we all have the same bottom line, and that's providing the right response at the right time. So maybe you can be the person in your agency or your organization to help with letting the discussions begin. Thank you.
Arlene, thank you so much. You did some excellent work on this paper. Really want to give you a lot of credit, and thank you, SAMHSA, for the partnership and funding this paper. There are a lot of questions in the chat box about this, whether or not law enforcement or how many 911 call takers are aware of 988, for example. And so, there are lots and lots of questions. And as Arlene noted, this issue is very important to SAMHSA and is part of their strategic plan. So really thrilled for that. Thank you so much, Arlene.
You're welcome.
Great. And moving to the next segment. Great. And this just talks about federal legislation and what's been going on. We are going to skip the federal update this time, but in the future we will have further updates on that. And this is the map of legislation that has occurred related to 988 in states where there's been the comprehensive 988 implementation enacted, which is the gold, and the green is the partial 988 implementation enacted. And then the gray is more of the non-considered and excludes appropriations and study bills. And then kind of this light beige, kind of where Pennsylvania, as well as looks like part of Delaware, are comprehensive 988 implementation pending, and that later blue, the partial 988 implementation pending. So we'll have further updates on that as well as things move ahead. Next segment. Great. Now, this is really cool. And I want everybody to hear me on this because there are a lot of segments to this. So first, in 2024, the International Initiative for Mental Health Leadership will have a leadership exchange. Okay, I encourage you to become a member of IIMHL. There's great information that other countries share, that we share with other countries. And that leadership exchange specifically, it's a larger meeting Thursday, June 27th and Friday, June 28th in 2024. And that's in the Netherlands. There is the travel day on Wednesday, June 26th. But prior to that, there's something called match opportunities. Now, these matches can happen all over Europe. In the Netherlands, they are very small groups to really address a specific issue. And we are really excited that one of the matches is the Zero Suicide Summit being held in Liverpool in the UK. So that's on Monday, June 24th and Tuesday, June 25th. And then after the leadership exchange in the Netherlands, there is the Crisis Jam in person, okay, for Saturday, June 29th and Sunday, June 30th. And that is just a fantastic opportunity. I don't think it's ever been done before to have a 2-day Crisis Jam in person. So really super excited. And noting what Karen is saying in the chat box there, we haven't had a Zero Suicide Summit in 5 years due to COVID. So it's back and very excited about that. So thank you very, very much for highlighting that. I hope all of you can join this amazing event. And I think there's a video, is that right?
Well, if you look around the room, there's a lot of people who are not only innovators, but really sort of willing to shake things up, even when it's very difficult to do that. So to have these people who you know, sometimes they're all alone in the organization that they're at saying like, this has to be different, but to have us all together, it's motivating and inspiring.
I'm from Cornwall, where I work in the mental health services.
I'm a GP from Cornwall in England.
From Leipzig, from the European Alliance Against Depression.
I'm from the Black Dog Institute in Sydney, Australia.
I'm from Houston, Texas. From Penn State University.
Institution in the northern part of Holland.
I'm from the Public Health Agency of Sweden.
I am from Sacramento, California.
I'm from Denver, Colorado.
I'm from China.
I came from South Korea.
I am from Charlotte, North Carolina. I'm from Japan, Tokyo.
I'm from Taiwan.
From the United States, from California. Or I'm from Canada.
From Australia, in Queensland.
I'm from London. I'm a psychiatrist and I'm from San Francisco.
I'm from the UK.
I'm a clinical psychologist. I'm from Groningen. So I'm from New Zealand.
Thank you. These events are so rich, and the networking and learning from others and what happens in their countries and what happens in ours is just awesome. We now want to turn it over to Vic Armstrong. Vic, take it away for strong talk.
Thank you,
You're
Megan.
so awesome. Thank you for being on.
September is Suicide Prevention Month, and as we plan Prevention Month activities, we want to be mindful that our initiatives should be geared to reach all communities, and that our goal is not to maximize effort, but to maximize impact. Whatever our outreach, it should be focused on creating impact, on creating access. But access is not only about having physical proximity to traditional resources. It's about having resources available to me that are culturally relevant, relatable to my lived experience, and that I am willing to utilize. Creating access is about creating relationship. Suicide prevention efforts have taught us that having open, supportive dialogue that builds trusted relationships, finds trusted messengers, and yields a trusted message can lead to life-saving action and interventions. Utilize the month to create dialogue. Efforts have taught us that having a robust system that is not punitive or stigmatizing, that is informed by individuals with lived experience, including historically marginalized communities, is protective against suicide risk for the entire population. Utilize the month to create an exchange of ideas. Efforts have taught us that providing evidence-informed, culturally sensitive, risk-reducing clinical care, including education and support for patients and families where they live, work, play, and pray, saves lives. Utilize the month to create sustainable, community-informed access. In order to engage communities for Suicide Prevention Month activities, don't just flood communities with information on research findings or brochures or panels or lectures, but form partnerships with community-based organizations and coalitions to increase community buy-in, to reduce stigma, and to increase impact. Work with community partners, community media, and grassroots messaging to educate communities, combat stigma, and address concerns about receiving treatment. Community collaboration affords us the opportunity to provide not only an evidence-informed response to the needs of those we serve, but also a community-informed response that impacts an individual's ability to navigate their own healthcare journey. That is impact, and that is strong talk. Thank you.
What's the word? What's the word? Word, strong talk, strong talk. What's the word? What's the word? What's the word? Yeah. What's the word? Strong talk, strong talk.
Vic, thank you so much. Your perspective is so valued, and you can see in the chat box, everybody, giving a amen on what you're saying. So,
And notice that I'm wearing my 988 hoodie today.
I like the hoodie. I haven't seen the hoodie before, so it looks excellent. So thank you, everybody. The next Crisis Jam will be from Charlotte Claiborne, who is going to present on the Bridge Center for Hope. That is in Baton Rouge. And then the one after that in 2 weeks will be on mental health resources by Google and IASP, which is related to the, I had it written down, but it has to do with pain. And that's Professor Rory O'Connor and Dr. Renee Schneider from Google. So thank you, everybody, and have a fantastic rest of your week. and weekend. Thanks for watching. And go look at the website at past episodes and gain a lot of knowledge and resource. Take care, everybody. Thank you.